Welcome back to lecture 2 of 2. My name is Yannick. Today we will build on CBME and safety, focusing on educational methods which bring CBME to life. Scenario-based teaching, team-based learning, interprofessional education and simulation with structured debriefing. We'll also examine how longitudinal integrated clerkships provide learning, and we'll work through 2 short clinical scenarios with entrustment insights. Our roadmap. First, how do we teach CBME in practice? We'll cover case or problem-based learning and TBL as active learning methods. We'll look at IPE as a team approach. Then we'll briefly touch on simulation-based education. Next, longitudinal integrated clerkships as a model of continuous, high fidelity, you could also call it real-life learning. Finally, 2 scenario prompts to apply entrustment principles. Scenario-based teaching, sometimes called case or problem-based learning, uses realistic patient cases to drive learning. As an exemplar, presenting a clinical vignette and asking students to work through diagnosis and management fosters application of knowledge. Team-based learning is a structured, small group approach. Students prepare individually, then take readiness quizzes, and finally work in teams on case problems. TBL's evidence base in medical education is strong. A recent review found implementing TBL, even if modified, generally improves student satisfaction, engagement, and often knowledge acquisition. It has become widespread since the early 2000s, adapting well to large classes and focusing on teamwork. So scenarios anchor learning in real contexts, for instance, simulating an emergency department case. TBL adds structured team interaction. Each student is accountable to their team, which enhances communication and collaboration. Instructors facilitate, but much learning happens in teams. The interactive format means misconceptions are addressed on the spot. In practice, combining scenarios with TBL, alternatively named team-based case discussions or the like, can deepen learning of clinical reasoning and safe teamwork. Interprofessional education occurs when students from 2 or more health professions learn about, from and with each other to promote effective collaboration and improve patient care. For example, pairing medical, nursing and pharmacy students in a case discussion or a simulation helps them understand each other's roles and communicate better. Studies show that interprofessional learning, especially through simulation, improves team communication skills and prepares learners for collaborative practice. Scenario-based IPE activities, like a simulated code team, give students a safe space to practice roles and voice their concerns, ultimately enhancing patient safety. Simulation is a cornerstone of CBME implementation. In simulation, learners, often in teams, manage a clinical scenario, say an inpatient decompensating, often using high-fidelity mannequins or actors. Crucially, after the scenario, an educator leads a debrief. The PEARLS tool was developed from simulation and educational literature to be user-friendly. For educators, it offers sample language and steps to ensure key issues are being discussed. Here's what we will need momentarily. For further details on this, please do watch the Debriefing the Debriefer webinar on this channel and in the YouTube show notes I did together with Thiriselvi Subramaniam last March, which you may find there. Research suggests that effective simulation and debrief aligns with error resilience. By analyzing what went well and why, learners build adaptive expertise. The brief also explicitly addresses safety concepts, like in the question, what prevented error here? In short, simulation with structured debriefing fosters both clinical skills and a safety 2 mindset. Another educational model aligning with CBME is the longitudinal integrated clerkship. In a LIC, students spend extended time, often a year, in a rural or urban clinical setting instead of short rotations. They follow patients over time, from clinic to hospital and beyond, and maintain continuous relationships with preceptors. As Eller et al. Note, LICs weave together continuity of patient contact, supervision, and assessment. Students essentially live an environment of real clinical practice. This continuity builds professional identity and lets students experience the full patient journey, which is high fidelity to actual practice. LICs also allow for entrustment decisions over time, reinforcing both learning and safety. Key pros include continuity of care and supervision, patient focus, and increased student engagement. As an exemplar, learners build confidence by managing a panel of patients and seeing outcomes. Studies report that LIC students often feel more prepared and connected to patients. The main challenges are logistic: matching schedules, ensuring a broad curriculum, and training preceptors for longitudinal mentoring. But many schools find the model enhances professionalism and provides a rich apprenticeship experience. So let's quickly revisit patient safety concepts. Important for us, Safety 1 focuses on preventing things that go wrong, investigating errors after they happen. I'm mostly referring to that during this lecture. But as aforementioned, Safety 1 and Safety 2 are complementary. We still learn from errors, but we also study and reinforce good practice. Let's apply these ideas. A medical student is handing over a postoperative patient and forgets to mention a severe drug allergy. The admitting team almost gave that medication, but you intervened. How would you debrief the student, and how would this affect your trust? On a side note, this involves the handover EPA you got to know during lecture 1. Well, by discussing the missed allergy, you would emphasize accountability and patient safety. In debrief, you'd use the PEARLS model. Ask for reactions similar to, what happened? What did you notice? And then analyze the error made non-judgmentally. Point out why omissions are dangerous and coach use of checklists or mnemonics. Regarding entrustment, this lab suggests the student needs closer supervision for handovers until they demonstrate reliably, including critical info. Factors influencing entrustment include the student's humility. Do they recognize the mistake? Reliability and capability. If they show genuine concern and willingness to correct, you might still trust them with small handovers but with oversight. If this repeats, entrustment levels must consequently be kept low. Let's take a look at another one. In a simulated code, the team did well overall, but the team leader, a senior medical student, delayed calling for backup when needed. In debriefing, you'd first highlight effective teamwork and the sufficient chest compressions. Then you'd ask what challenges they felt. The leader's hesitation reveals an entrustment issue. They had capability but lacked assertiveness. So your feedback? Encourage recognizing one's limits and promptly calling for help. For entrustment, you might say, "You're competent clinically, but next time I'd want you to call sooner. I trust you to manage initial care, but when in doubt, do delegate or ask for help as well. This corresponds to saying they are ready for indirect supervision in resuscitations. As they're emphasizing trust factors, the leader's good performance shows capability, but they must build reliability in crisis management. In a nutshell, future entrustment decisions would hinge on observing improvement in their leadership. From these scenarios, note that entrustment isn't just about checking off skills. It involves trust factors like reliability, can I count on this learner? Capability, do they know what to do? Integrity and humility. As supervisors, we weigh all these. For instance, if a learner shows humility by admitting mistakes and seeking help, that fosters trust. In EPA-based programs, formal entrustment decisions, which means signing a learner off on an EPA, occur when evidence is strong. But many day-to-day decisions are ad hoc decisions. Always remember, entrustment means the trainee has earned the privilege and responsibility, but we must remain vigilant. If a safety issue arises, then we step back. In summary, CBME comes alive when we use active, authentic methods. Case discussions, team-based learning, interprofessional simulations, and longitudinal clinical experiences. Structured debriefing like pearls ties these back to both clinical competence and safety. Longitudinal clerkships immerse learners in real practice over time, exemplifying CBME's goals. Through it all, we make entrustment decisions guided by well-defined EPAs and a holistic view of competence and trust. Thank you for participating in this and the formal lecture. Please do keep these principles in mind as you design and teach in your programs. Thank you as well for listening, and I hope you will enjoy the oncoming live webinar this was meant to get you up to speed for.